All right, good afternoon, everyone. Can you hear me okay in the back? Sounds all right? Okay, all right. All right. Good afternoon, everyone. Thanks for being here today. Really a pleasure for me to invite you or welcome you to this year's Global Health and Equity Symposium. So this is a really great gathering, and it's great to see a room full of folks interested in the topic. It really represents an opportunity to recognize the depth of scholarship across Brown and the commitment of our students and other trainees to advancing health equity in communities around the world. I want to begin by, of course, thanking Adam. Dr. Levine is the director of the Center for Global Health Equity, the entire center team, and everyone else that helped bring this event together. And most importantly, I want to recognize our students and trainees whose work is really central to tonight's program. What makes the program really special is that it reflects something larger than a single day of presentations. It reflects a mindset and a belief that advancing health is not just about discovery, but about how people benefit from those discoveries. A recognition that science, when coupled with equity, has the potential to transform not just outcomes, but systems. And a commitment to ensure that innovation reaches communities locally and, of course, globally, where it's needed the most. And what's especially meaningful is that much of the work is being led by many of you in this room, our students and trainees. You're asking hard questions, working across disciplines, engaging directly with communities, and that's really remarkable. And in doing so, you're helping define what the future of global health should look like, one that is collaborative, inclusive, responsive to the realities on the ground. Tonight, we also have the privilege of hearing from a leader whose work exemplifies that ethos, Navin Salem. Through her leadership of Odessia, she has demonstrated how science, innovation, and mission-driven action can come together to address one of the most urgent global challenges, childhood malnutrition. Her work is a powerful reminder that impact happens when we move beyond ideas and commit to execution at scale. As we begin this evening, I really want to encourage all of you to take full advantage of the conversations, the presentations, and the connections that will unfold here. Because events like this are not just about showcasing work, they are about building community. They're about sparking new ideas. And ultimately, they're about making an impact. So thank you everyone for being here. This is an incredibly important effort. Thank you, Adam, for your leadership. Again, I want to welcome everyone to this year's program. And with that, I'm going to turn it over to our Master of Ceremonies, Adam.
Thank you so much, Dean Jane, for getting us started here. And I am so pleased to be here with all of you at our Global Health and Equity Symposium. For those of you who've been around for a few years, you may have noticed that the name of this event has changed. It used to be Global Health Research Day for many, many years and was always a very successful event. But some folks pointed out that, in fact, the event takes place in the evening, not during the day. So Global Health Research Day was not totally appropriate. And in addition to that, we really wanted to emphasize and make crystal clear, especially with the establishment of our new Center for Global Health Equity last year, that what we do is not just about Brown students and faculty traveling to other countries and doing research or training. It is about reducing healthcare disparities wherever they occur, right here in Rhode Island, in Africa, in Asia, and everywhere in between. In fact, much of the work that we do here in Rhode Island has important ramifications for work around the world, and we have the opportunity for engaging in reciprocal innovation, where the new tools and strategies that we use to improve health in other countries can actually be used to improve health here, and vice versa. I work on our street medicine team here at Brown, and I'm always fascinated by how caring for people living in homeless encampments here in Providence feels so much like caring for people living in displaced persons camps in South Sudan that I've done in the past as well. And we know that life expectancy for the average person in the state of Mississippi is actually the same as life expectancy for the average person in Bangladesh. There are many, many ways in which we can think about bridging these disparities, both here and also abroad. And so with that in mind, we have changed this to our Global Health and Equity Symposium to make that clear. I am thrilled today to welcome our keynote speaker, who will be starting us off with a really fantastic set of thoughts about her experiences. We are bringing to you today Navin Salem, the CEO and founder of Adizia. In 2009, Navin set out to help end the crisis of global malnutrition by founding Adizia, a U.S. nonprofit social enterprise with a mission to treat and prevent malnutrition in developing countries worldwide. Her factory, right here in Rhode Island, produces a range of fortified peanut-based products like Plumpy Nut, which you will all have a chance to get your own packet right afterwards, for humanitarian agencies like UNICEF, the World Food Program, and other NGOs working in emergency and conflict zones all over the world. Since 2010, Adizia has reached over 25 million children in 65 countries, including Somalia, Venezuela, Yemen, and Syria. Navin is also a 2022 McNulty Prize winner, was an Earnest and Young Entrepreneur of the Year in 2018, a New Englander of the Year by the New England Council in 2017, and New England Businesswoman of the Year by Bryant University. She was awarded honorary degrees by her alma mater, Boston College, as well as Bryant University, Providence College, Curry College, University of Rhode Island, and Salvo Regina University. So for those of you who think you have a lot of degrees, she has more. She is a 2014 Henry Crown Fellow of the Aspen Institute and a member of the Aspen Global Leadership Network. Navin's father is from Tanzania, and she has 4 daughters, all of whom were the inspiration for the creation of Adizia. Let's welcome her here to Brown University, and we are so thrilled to have her join us today. Thank you.
Hi, everyone. Thank you for being here. I first just want to address the title of this symposium, Global Health and Equity. I think those words are very interesting. Let's imagine for a minute that you have a 2-year-old that you bring to the pediatrician. And you bring your daughter in, and the pediatrician says, you know what? She's not quite very sick. She has a fever, she has a cough, but she's not really that sick. Why don't you bring her back when her heart is barely breathing, when her skin is tearing, when her organs start to shut down? Then bring her in, and what we can do is we can save her life. Right? Would any of you in this room say, that's totally fine. I'll go home for a while, and I'll come back when my daughter's in maybe days or hours away from passing away? Anybody in this room okay with that? No. We would have an uprising, absolutely, if that's what we were told when we brought our children to the pediatrician. And when we talk about global health, I often wonder, why is it so different than health? Why do we even have a different name called global health? What does that mean in that difference? And why are we treating patients differently based on where they live or they were born? And I actually am in the business of saving lives, and I think it is the wrong business to be in. And this is something that we want to stop doing, that saving lives is actually not a great idea at all, that there's so many better ways to address the problems that we have. And so that's just while I was sitting there, that's what I was thinking about. So here we are. So we're just going to start with a quick little video. Lights.
Russia's invasion of Ukraine is deepening the global food crisis.
Extreme weather, supply chain disruption, an apocalyptic global food shortage.
I feel like the world is on fire right now. Conflict, wars, climate change, the inability to grow crops. When you put those things together, you are for sure going to have a crisis of malnutrition.
I know what it means to be waiting for humanitarian aid. I experienced hunger. I've felt the pain, and I've seen children die.
3 million children every single year will die from malnutrition, and 100% of those deaths are preventable. I know, you don't feel good today. "24 hours a day, we are making these fortified peanut butters that are used to treat all the different phases of malnutrition. It's like food by prescription. You're able to completely transform a child in just 8 weeks. The Odysseia community is full of former refugees from 26 countries. The majority of our team has lived through a crisis like this.
We have the logistics and manpower to get the shipment all the way to destination.
We can directly relate. I have seen kids come from skin and bones to happy children that are gaining weight. They're talking, they're singing, they're dancing. I never thought I was going to be able to make an impact at the scope at which we've done today.
When you see the transformation in such a short time, that just fills your soul with hope. We can end malnutrition. That's what motivates us every single day. So perhaps you blame your parents for everything. I blame my kids for everything, just to turn it on them. You can tell them that, Georgia? Okay. So I was a 35-year-old mother of 4 children under the age of 5 when I started Odysseia. And the only reason I mention that is because somehow that became the target population that we work with at Odysseia every single day. And this journey has been, a very personal one. My grandmother, my father is from Tanzania, along with my grandparents and great-grandparents. And my grandmother lost 2 of her children before they turned age 5. And my grandfather died of tuberculosis at 34 years old. So I grew up with this being part of our family history and what we grew up with. And so when I had my own daughters, and I was struggling just living in Rhode Island trying to make it through the day, and I was thinking about mothers in other countries like Tanzania and how difficult it must be to have children and make it through all of the extra challenges that they have. So I headed to Tanzania, and one of the things that I saw first, I was at the hospital actually where my dad was born, and I saw a mother collapse to the floor. And she was on the floor because she had just learned that her son had died from malnutrition. And I thought, how can this be in this day and age that we are losing children to something that is so basic and so simple? And we know that every child in the world needs food and nutrition in order to survive, and yet this is what was happening. And what if this was my child? To lose a child from something that's so simple and so basic that we could prevent from happening. 50% of childhood deaths result from malnutrition. So if you have if you are malnourished and you have malaria or pneumonia, you are much more likely to not survive that versus if you have that good nutrition in your system. And so the fact that 1 in 2 is a result of that lack of nutrition said, there's something we have to do here about this. So Adicia is a nonprofit social enterprise. So that means we're also like a business. So we're a nonprofit and we can raise money to be able to deploy everything that we need to do. But we also run like a regular business as well. And that allows us to do things really at scale. So this is all of the products that we make here, and we're doing the entire range from severe acute malnutrition to moderate to acute malnutrition to prevention. Most of these foods are for children under the age of 5, but we also do pregnant mothers. Do not judge for the acronyms. I did not invent any of those. Those are from the government. My personal favorite, PBWG. First of all, I take offense to what that actually stands for. It's pregnant and breastfeeding women and girls. Ouch. Like, no. And for so many reasons, I wish that I was on the branding team, but I'm not. SF stands for school feeding. And so we're really looking at everything from pregnant mothers to school children to babies to children under the age of 5, and looking very specifically at the challenges that they have. And everything that we do here has gone through studies that have evidence to prove that the nutritional outcomes are very specific to the needs of those children in those different spaces. A severely malnourished child, so the way that we measure is it's called a MUAC tape, mid-upper arm circumference. And so we're measuring the mid part of the arm right here. And if you look at, this works for anyone under the age of 5, 6 months to 5 years of age. This is the size of a severely malnourished child's arm. For those of you in the back, this is about the size of a quarter. And once a child has been on RUTF, ready-to-use therapeutic foods, or Plumpy Nut, then this is the change that we can see happening in 8 weeks. And so that transformation is unbelievable to watch. You can see it even happening on the first day. The way that the children start sitting up, immediately they start playing with toys that they weren't. The malnutrition wards are silent. You could hear a pin drop. And then the minute that the feeding programs start, they're sitting up, they're playing, and interacting with people almost immediately. So these products are made with peanuts, milk powder, vegetable oil, sugar, and lots of vitamins and minerals. And we work with the U.S. government sometimes when they want to engage with us. We'll talk about that in a little bit. And we are shipping to 65 countries. So countries that are experiencing conflict and climate change, when you put those two together, for sure. So Sudan is probably ranking number 1. Afghanistan, Yemen, Syria, Venezuela, Gaza, Mali, Chad, Nigeria, the list goes on. And so while we're doing this humanitarian work and shipping to all these countries, we're also a manufacturing company that runs with 150 employees 24 hours a day, usually in trying to keep up to make sure that the supply chains don't break amidst all the many, many challenges that we have. So I thought it'd be fun to tell you a few stories from last year, and I am going to leave plenty of time for questions, so make sure you figure out what I didn't tell you and what you want to know more about. So last year was so fun. On January 20th was Inauguration Day. It's a big day. I'm in Sierra Leone with Ron, and we're in a clinic in Sierra Leone, and there's a room full of mothers and children, full, waiting to get weighed and measured. And there's 4 boxes of Plumpy Nut in the corner of this clinic. And on my watch comes up an alert that says, U.S. foreign assistance to be paused for 90 days. And I'm literally standing there looking out at this room as full as this, maybe even more full, and saying, how are these 4 boxes going to last? And which of these children is going to get one of these boxes? that was a day I'll never forget. USAID was 85% of our business, so pretty much going to zero. So I think for about a day, well, first of all, stop work orders came in. We didn't stop. Cancellations of our contracts. They broke the payment system on purpose so that we couldn't get paid. And every day there was something that was delivered to our inbox that was quite shocking. My first tweet that I've ever sent in my life was to Elon Musk. He wrote me back. He said, "We're going to pay you." It still took a couple of months after that. And for about 2 days, I was quiet. I sat at my desk trying to think. Department of one had quit in December. So I was like sitting at my desk by myself saying, all right, what are we going to do with these journalists who are calling? And I just said, you should stay quiet. You should stay quiet. Just let it go. You're going to get in trouble. And then 48 hours later, I'm like, yeah, we're not doing that. We are going to talk to every journalist on planet Earth and tell them what's going on and fight for our cause and our mission because it matters. And the government kept saying, you know, life-saving humanitarian assistance is important to the administration and that's not going to get cut. But at the same time, nothing was happening. So when Secretary Rubio says no children died during this debacle, that is not true. We were watching clinics close down almost immediately, supply chains completely stopped. Boxes stuck, millions and millions of dollars of boxes stuck. We had boxes on the water. We had boxes in warehouses, boxes everywhere that were supposed to be frozen somehow. So I think I ended up talking to about 100 different journalists, make sure our story got told and that our stuff would start moving. And there was a whole series of things that we did in order to beat the government. So, number one, understand the landscape. So one of the first things I did was read Project 2025. How nice of them to provide a roadmap for me. Chapter 9, USAID. I could read exactly what they were planning for this department. Now I had to read it with an open mind because I needed to find what do I agree with here and what do I disagree with, because I need to align on something, right? So I found a few small items that we could do. You know, one of them was I learned to speak a new language. It's called America First. And, you know, what makes us safer, stronger, and more prosperous. And so I was like, I can use a new language. I have already learned how to speak acronyms, so we can learn this as well. That's fine. And one of the things that was really interesting is that, so I had a factory in Tanzania first. And when I was at USAID one day, they said, we need a factory in the United States. And we needed to be a non-profit food aid manufacturing company, which there weren't any at the time, because there's a few grants that are available for that. And we need you to buy everything, every commodity from the United States. So from farmers in red states, right? So we buy commodities, peanuts, milk powder, sugar, etc., from 17 different states, mostly which are red. And so I immediately realized we have like a little security blanket here. Number one, they said they care about life-saving humanitarian assistance more than anything. And we are supporting farmers, not little tiny little contracts, $100 million worth of commodities that we're buying. And we're also represent U.S. manufacturing, right? And so all of those things were big wins. And what's the opportunity of shutting something completely down? Well, maybe there is the opportunity for change. Maybe there is an opportunity for efficiency. I haven't seen it yet, but I do keep sending memos to give them some suggestions on how we could be more efficient, and strangely they haven't gotten back to me yet, but I'm still here waiting and still sending them memos to remind them that these are opportunities. Align with unusual suspects. I became best friends with my competitor. I figured we're either going to rise together or we're going out of business together. And so that was really powerful. And so you have to, in a time of crisis, really look to the opposite of what you have done every year up until now. And so me and my friend Mark became best friends. We talked every day, and we decided to do these interviews together so that we were both in the articles. And so if the U.S. government wanted to take one of us down, they had to take both of us down, and that would be the end of anything in this space. One of the other unusual suspects was Doge. I decided to befriend Doge. We became best friends. We talked twice a day. I would educate them. Remember the Department of Government Efficiency? Remember way back? I know they don't exist anymore, and you probably forgot about them, and I tried to as well. But we became best friends and talked twice a day as well. And I would educate them and tell them, you know, here's why it's important. Here's what doing food aid and international aid well, this is what it looks like. This is what we should be sharing with the American people, right? Because we should be super proud of these initiatives. And he said to me, I'm going to get fired. And I was like, well, I can think of worse reasons to get fired than having a heartbeat. So you go back down the hallway and keep telling them that how important this is. Feeding children, thankfully, has always been a bipartisan issue. And so this is very important to understand that it still remains a bipartisan issue, and that the majority of people think it's a good idea to feed children, whether it's in the United States or it's halfway around the world in Afghanistan. And then the last thing was to make change immediately. And so this meant we were going to do everything that we used to do differently. I did not hold a single meeting to ask anyone what they thought about this. There was no strategy sessions, nothing. We didn't have time. I thought that we were going to close down at least 4 times during this year. So we need to make change really quickly. So what did we do? All right, so we don't have the US government. We're not really sure what the United Nations is up to either. So if we were to do this alone with us plus NGO community plus Ministry of Health, how are we going to organize this? So we decided in 2 days, we came up with a Children Can't Wait campaign and started raising money. The 100 journalists who were writing stories helped us raise the money because they were bringing awareness to our crisis, and they loved that we were up against the government, right? So that gave everybody like someone to, something to fight for and a way to channel your frustration with action. And so we ended up raising $5 million, and we started making these coalitions. So a coalition looks like this. If we are going to get into Gaza, all right, well, I know a guy on the board of the United Airlines. All right, United, come and pick up this stuff in our warehouse in New York for free. Fly it to Tel Aviv. In Tel Aviv, we have a partner called Israel. They go and get us all the government consents that we need and paperwork to move it. Israel drives it to the Gaza border. Multi-Faith Alliance picks it up on the Gaza border and distributes it door to door and to clinics. No interference from governments, from the UN, or the United States government in particular. And so we realized we can do this. So we can now build coalitions that are very specific to each different country. And we had never done this before, right? So it's like a completely different way of working. We started a new warehouse. We said, well, maybe we need to get better at last mile delivery, and that our products need to get not just to the port and we leave it for UNICEF to pick up, but instead we want to get it right to hospitals, right to clinics, and maybe someday even right to the door, right in the hands of a community health worker that can distribute it to children door to door. How amazing would that be? So we started a new business in the middle of closing down. None of this makes any sense. My brain wants to grow things. And so even in the midst of like we're shutting down, it still kept growing at the same time, trying to also slow down, which is an impossible thing to reconcile in your brain. But we now have a new warehouse in Ghana where 10% of our food now travels through that pre-positioning warehouse. Now I can get to countries in a matter of days, not weeks, right? Because the urgency is really what matters. So where are we today? This is a couple of the things I was just talking about. So we're a member of a network of 7 countries where we have local factories. So in Madagascar, Nigeria, Haiti, India, Ethiopia, Egypt, etc. And so that allows us to have partners that are already there in malnutrition hotspots where we can partner with them. You know all about Life Saving Foods, coalition building, that's what I just spoke about. The last mile logistics is now new. Research, we actually ended up getting a grant for $2 million from the Bezos family for research. So we're looking at new formulas, new ways to deliver and program. For example, malnutrition shouldn't be a standalone. What if we paired it with immunizations? What if we put it in with TB and as many global health areas as possible so that you're not paying to deliver only for one sector, right? And how can we also make this an incredible incentive for mothers to come in to the clinic as a well baby visit that comes with a whole host of services? We've turned that research fund into $9 million, and we have deployed in 13 countries just in the last 18 months, and that's growing. And the last thing is advocacy. We spend a lot of time in Washington, D.C. I will give our Congressman Magaziner a shout out. During the crisis, he stood up on the House floor 33 times in a row and said he would not go away or shut up until ADCA got their funding restored. So even our politicians here are hugely supportive of what we do and what so many do, and we're really grateful for that as well. All right, I won't because I'm talking too much. Where's my little clicker? Okay, so what's next? This is a secret. You can't tell anybody that I showed you this picture. I know it looks like a pile of mud because it is, but while we were in the midst of closing down, secretly we've been building. So everything except for this, from here to that gray building, everything around that is being built right now. So we will now be opening a 300,000 square foot facility this fall that will double our capacity. So while we've reached 30 million children in 16 years, we'll now be able to reach a minimum of 10 million every year going forward. And so somehow we found the resolve to say, keep building this. It's all going to come back someday. And maybe it will even come back stronger than where we were before, because we've taken a chance to do things differently, taken that opportunity. And so we are very excited, mostly for grass to start growing around this building, but to be opening it and celebrating that this is going to be an epic milestone and landmark in Rhode Island, where we can say that we are able to reach children once again in these huge numbers and these huge capacities all around the world. So, questions.
Anyone with a question can raise their hand and I'll come to you on this side. If you're on that side, Eileen will come to you.
Hey, hello. First I wanted to say great job, great presentation, really enjoyed it. But I wanted to ask, why peanut butter or why peanut paste? Like I know on one side you've got like preserves well, nutrient dense, great macronutrient profile, but on the other side you've got like allergies as well. So how did you and Adija come to basically deciding that you guys wanted to supply peanut paste?
Yeah, so first, I don't take credit for inventing the formula. It was a French pediatrician that invented this back in the 90s. And in fact, Plumpy Nut is having its 30th birthday in 2 weeks in DC. So, but you mentioned two reasons that is absolutely true. So nutrient dense, and it's able to hold all of those, the micronutrients. They don't taste very good, right? And so children who are severely malnourished and hungry are still picky. So we have to make food taste really good no matter what state you're in. And so it masks all of those micronutrients. It tastes good. So the shelf life is super important. And peanut allergies, we just don't come across peanut allergies. I'm sure you guys are all very aware that the AAP changed the recommendations maybe 10 years ago to say that allergens should be introduced early and often in order to make your immune system work hard and fight back from a young age. So children in other countries that aren't the United States, their immune systems are challenged just more naturally than ours are. And so that's why we just don't see that problem of peanut allergies. The other reason that peanuts are important is they're grown everywhere. And so if that's why we can have a factory in Madagascar or in Niger, because we can get ground nuts pretty much anywhere that you go.
Question here.
Thank you so much for the really great talk. You had mentioned earlier that there seemed to have been maybe a directive from USAID at some point to switch manufacturing to the United States. And now, given the situation, I'm curious if there's been thought about creating more local manufacturing closer to where you're delivering. And could you talk a little bit about the challenges of that?
Yeah. I mean, anytime I want to feel better about myself, I can go to a meeting with our partners in the field who have challenges with electricity, with water, with everything, you know, conflict. Like in Haiti, we raised money for a bunch of our partners, and Haiti wanted money just to build a higher security wall, right? There's gangs that are running all over the country. So we don't have to deal with those things, and we're very grateful for that. It's also very expensive to build in conflict zones. So while we're near these important children, so like we had a factory in Sudan. Within the first month of that war, it was bombed and destroyed completely. This family who runs the factory there is very resilient. They moved to Egypt, and I was just there in November. They opened a new factory near the Suez to be able to retain operations, but it's really hard to operate. We were trying to open one in Afghanistan. The head of the factory was kidnapped by the Taliban. Like, I don't have to deal with that in Providence, right? So it's hard, but we're coming up with innovative ideas. Like, we have this idea that we could build a micro factory in a shipping container. Well, 3 shipping containers. And if we could build these factories out here and then deploy them somewhere that maybe would stay for a year or something like that, where you could use local commodities and have that connection with the economic development, as well as being able to do your own local manufacturing. It could stay there forever. It could stay there for a year. It's really up to the person that we decide to work with. So we're trying to come up with ideas that are like almost in between that as well, that could be a little bit more mobile, and test out kind of these new innovative ideas.
Hi, just wanted to ask about the logistics of delivering during like an active conflict, and if you've ever had any problems with getting the aid out, especially with the politics of each like specific conflict, and how to safeguard against any interruptions to the supply chain.
Yeah, great question. So normally when we're doing a new country, we'll send something like a small shipment that's like a test. So when we first did Venezuela, we sent a very small amount and tested the system. That one was kidnapped. So we tried again, though. It's just like you've got to make adjustments, right? So then you send another small one out and you find a safer route, and then you can go bigger, and your risk has been lessened. I mean, in Gaza, we failed the first 2 times. So we had trucks looted. We had trucks coming in on the Jordanian side and also on the Egyptian side. When we finally figured out this route, partnering with IsraAid, that was kind of our key to crossing a border in a different place. So always start small, test the system, and then, you know, we're also keeping our eye on things like the black market and making sure that products aren't leaking into the black market and being sold. So that's a very important thing too. And so there's actually ways around this. So we can say if you're given 30 packets and you come for your next check-in 2 weeks later, that you have to return the empty packets. And that way we know that this child, because if we don't see growth, weight, and height, we know that either there's sharing going on in the house, which is, that one's just really hard to deal with, because how do you keep this, even though it's a food by prescription, away from other children? It's very difficult, right? So sharing can be a problem, but also maybe selling we have no tolerance for. So we want to be able to have a way to be able to measure and make sure that those kids are getting that full prescription that they've been prescribed.
thanks for coming to talk to us. Of course, climate change is a driver of malnutrition itself. Could you tell me about some of the climate-friendly considerations you've made for distributing the products?
So, I mean, at Adicia, one of the things that we're trying to do is change the way we work. So it can be as simple as putting solar panels on our roof. We're implementing, actually, I don't know if you can see it in that picture, but we'll have 3 train stations. Why train stations? Well, we can take cars off the road. So all of the efforts that we're doing are better for the environment, but also they're lowering the cost. So we're trying to figure out how we can make these foods for the smallest amount possible so we can reach more children with less dollars. One of the things we haven't cracked that I would love to, if anyone knows how to do this, making our packaging recyclable. But the UN requires it to be, no UV light, and it has to survive in very harsh conditions for 2 years. And so it's hard to put something flimsy that's biodegradable and also survive like really harsh, hot conditions at the same time. So that's something we continue to look at, but we haven't been successful in the past. And we also, this is a really fun idea, some of our boxes can be made into toys. So you can actually build a truck if you punch out the outlines. And so kids can have something to play with as well, instead of just having a box that gets thrown away.
First, I just want to thank you so much for coming here. Your talk is incredibly inspiring. My name is Alethea DeRogers. I'm a faculty member here in the psychiatry department. As an aside, I just have to say it's really lovely to find more people who have been to Sierra Leone. I have a couple of projects there and have traveled to Freetown several times. And I have a postdoc back there hiding who has also done the same. My question is, I love this idea of packaging and kind of leveraging that you already are delivering the plumpy nut. Thank you. For malnutrition, and maybe you could address TB and some other things that are of great prevalence in some of these settings. Do you have any ideas for how to expand that packaging to include things like addressing different NCDs or prevention, or like I'm a mental health researcher. I do a lot of work with early childhood development too and positive parenting practices. But if there's a mother coming to a clinic to pick up a packet, do you have any ideas for how you might even expand it to address even more kind of challenges that aren't just like an infectious disease or
yeah, absolutely. I mean, even nutrition education and counseling is important as well. So I think that there's a lot of different factors. We'd like to lump them all together. Working with ministries of health is really helpful in that context, because they have thought about a lot of these things. And then how do we facilitate, instead of just advocating for our own space, it's really advocating and making sure we share our resources, right? So it kind of has to start with the funders as well, to share those resources and make sure they get spread around all of those, from NCDs to education and things like that. So that is the single goal of our research department, so we're partnering with the Gates Foundation, with Boston University, University of Ghana, Johns Hopkins, many in academia, but also other partners that are coming together to look for these opportunities and these solutions and do something about it. So, reach out to us, and you can see what other research studies we have going on and which ones are coming up, and we're always open to new ideas as well. But it's like, how do you do everything but also stay focused enough that you're successful in the things that you set out to do? So always a balance. Mr. Lorne.
I'm wondering 2 questions. One is, what percent of the problem do you feel you're addressing now, and what are the goals?
Mm-hmm.
And number 2, are there countries other than the U.S. that have anything that looks like USAID that you're having conversations with?
Yes. So the really sad part about this story is there was a time when we reached 25% of the world's malnourished children, and then it was 50%, and then it was close to 75%. And I said to everyone, There's no way we would go backwards. This is like one of the most incredible success stories in global health history, is to increase that coverage like that. I said, no chance we'd ever go backwards. So this was 2023 into 2024. And then I was as wrong as could be. And so this like crushes my soul that we built up funding, capacity building, programming, literally every stage of this that has to happen to increase the coverage. And we got there, and then we went completely backwards. So where are we now? I have no idea where we are right now. The U.S. government has placed one order since January 20th. One. It's pretty hard to run a business with one order. A new tender came out on Friday, hasn't been awarded yet. That would make us two. So it remains to be seen. What are we doing about it? Yes, I'm talking to other countries. And I'm like, I have a halo. Would you like to borrow it? Because I don't need it, but you do. So imagine that the United States has pulled out of 9 countries: Afghanistan, Burkina Faso, Cameroon, Mali, Niger, Chad, Somalia, Zimbabwe. And some of these countries have the highest, these were in our top 3 countries that we were shipping to, right? So huge needs. And the U.S. decided we're not going to ship there anymore because there's no rare earth minerals, or we have no interest anymore. It's not related to how many children are at need at all. It's related to what kind of transactional relationship can we have. And so I probably shouldn't tell you which countries I've called, but let's just say they're like some of those Gulf states who, might have an interest in Syria, Yemen, Afghanistan, Gaza. And so the need is enormous there. And so I am talking to other countries to say, I can brand this with your country, because what we call soft power is actually really important part of what we are doing. So every packet says, from the American people. So imagine that your child is malnourished and maybe a few weeks from dying, and this magical food comes in, and every day, 3 times a day, it says, from the American people. Do you think you'll forget what country it was that saved your child's life? No chance you'll forget. So now this is an opportunity for another country to say, I'll take that halo. I'd be happy to send those messages out every single day to countries and regions that are important to us. And so, unfortunately, we're leaving a vacuum here, and it's for someone else to pick up. For me, I might have sounded a little political. I'm not supposed to. We are not political. We feed children no matter where they are. 6-month-olds don't have politics, right? And so our job is to get food to every 6-month-old that we can that needs it. And so who funds it and how it gets there and all that, I don't care. I need to get food to children because it's the right thing to do. And so that's what we're working on.
We can take a final question.
Oh, how are we going to choose? There's
up to you.
Oh, that don't make me choose.
Eileen.
You can come see me after class.
Hi. Thank you for an incredible talk and for all the work that you do. It's really inspiring. I'm curious to know how you track patient outcomes. We all know that tracking or collecting data in global health settings is very challenging, especially robust data. So I'm curious to know what your process is.
Yeah, so this is for the NGOs are the ones who are tracking this. But we do work, one of the studies that we're going to be working on is with a group called Symposium, who is apparently thumbprints, fingerprints don't work on babies, but eyes do. So we're looking at trying to do biometrics in a different way that works for an infant, and trying to get their records then attached to that so that we can have that record travel with them for the rest of their lives. A lot of times what I see is, you've got tablets there, but then they're also doing the paperwork as well, because maybe the government requires it this way, but your NGO has this technology. So there isn't enough uniform. I haven't really seen it done well. There's a lot of people trying to do it better. That being said, we do see cured rates, defaults, relapses. In fact, one of our studies is about the relapse in particular, and how to treat that so that they are less likely to relapse, because those numbers are actually starting to trend too high. And so what can we do both before and after to lessen that relapse percentage? So there's a lot of room for improvement in that area too. Thank you, everyone. I appreciate you having me.
Thank you so much, Naven, for joining us today. We have a small token for you. Thank you so much. We really appreciate it. Okay, I am so excited to move into our next portion of the Global Health and Equity Symposium. And here we get a chance to really recognize and honor our trainees, our students, and our residents and fellows and postdocs who have been working on global health and equity research over the past year or more. We have over 60 posters, 60 different student research projects that are being presented at our poster symposium, which I'm hoping all of you will get a chance to join afterwards. And it was a very difficult process, but we selected the top 3 to present here a full oral presentation of their research. And so I am very pleased to welcome our first presenter in the category of Best Undergraduate Abstract, Yui Miura. Please come up.
Hello everyone, I am Yui and I'll be presenting Mental Health Among Rohingya Children and Adolescents, a mixed method study. So before we begin, I'd like to introduce you all to Tabarak, a 15-year-old Rohingya who dreams to become an engineer, just like any other young, passionate person. However, Tabarak thinks he has to abandon his dream because first, he is a displaced Rohingya, lives in refugee camps with insufficient education, and he has no hopes for the future. His story is one of many where children are forced to abandon their hopes and dreams for the future and live in constant uncertainty. So I'd like you all to keep this in mind throughout this presentation. So, who are the Rohingya? The United Nations have called them the most persecuted minority in the world. They're a Muslim ethnic group from the Rakhine state of Myanmar, and since 1982, they have been denied citizenship, making them a population with no country. In 2017, military violence forced over 700,000 Rohingya to flee across the Myanmar border to Bangladesh. Today, over 1 million people live in Cox's Bazar in Bangladesh, making one of the largest refugee camps in the world. They face overcrowding, natural disasters, lack of food, hygiene, and medical care. These conditions make children especially vulnerable to mental health issues. However, research on this population remains limited, and this makes this study on mental health on Rohingya children very, very important. Health and Education for All, or HIFA, is a nonprofit organization founded by our very own faculty member, Dr. Ruhul Abid, and is providing medical care to the Rohingya in 2 of these camps. They treat a wide range of health issues, and HIFA has expanded into child and adolescent mental health. However, HIFA faces major time and staff shortage. They serve about 340 patients daily, and traditional mental health screening tools take around 20 minutes per person, which makes it less ideal in a humanitarian setting. To address this, HIFA developed a shortened 12-item screening tool, taking a few questions each from existing tools, such as the PHQ-9, which measures depression. And this questionnaire, based on patients' scores, classifies patients into low, moderate, or high risk. Patients at moderate or high risk are flagged and referred for further care. So this study aimed to assess 2 things. First, the current state of mental health among Rohingya children and the factors that are affecting their mental health, and second, the effectiveness of Haifa's shortened screening tool. We used a mixed methods approach combining both quantitative and qualitative analysis. So, for the quantitative analysis, we extracted mental health screening data from NEROG, which is Haifa's solar power electronic health record system, and we conducted a retrospective analysis using R. The results were very, very surprising. 99.8% of over 14,000 adolescents were labeled as low risk, with only 24 referrals in 1 year. At face value, this data suggests that almost no mental health issues in these camps. To explore further what is actually happening, for the qualitative analysis, we traveled to Cox's Bazar in Bangladesh and conducted interviews with 8 Haifa healthcare workers to identify factors that are affecting the mental health of adolescents. We classified the interview results into themes by using the Braun-Fant-Brenner's Process, Person, Context, Time framework, or the PPCT model, which explains an individual's development through 4 factors. First, the person, which is the individual characteristics and experiences. Process, which are interactions between the individual and immediate environment. Context, which are family and cultural systems. And lastly, time, which are individual life course and historical time. So, for the first person category, key factors that were influencing the mental health were gender and traumatic experiences. Young women and girls face greater mental health issues than men, with limited education, forced early marriage, and household burdens. Traumatic experiences was a major factor, as well as many adolescents experience flashbacks of war and sleeping issues. For the process category, which are interactions between the individual and their immediate environment, we identified harsh living conditions in the camps. In addition to this, a lack of education and employment were huge factors influencing anxiety and depression. For context factors, stigma around mental health and the culture of remarriage play major roles. Many Rohingya think that mental illness as being mad or crazy, and many avoid referrals or even treatment. And the culture of remarriage is where men remarry multiple times, often leaving their first families or engaging in domestic violence towards prior wives, creating emotional instability in both children and young mothers. And lastly, for the time, duration since displacement really matters. Those displaced since 2017 show chronic hopelessness, while newer arrivals may initially feel more hopeful as they come to the camps with expectation of shelter, food, and support. So, combining the findings from both quantitative and qualitative data, we see a clear discordance that the screening tools are showing a very low prevalence of mental health, while interviews suggest a significant mental health challenge among the Rohingya adolescent and children. And this suggests that the Haifa's 12-item screening tools may have an insufficiency in identifying mental health issues in this population. And why is that? Is this with the screening tool itself, of how it was designed and it was shortened, or is it something deeper? And some possible explanations include stigma and fear of being labeled, as we talked about, and the fear of referral, which is leading to underreporting, normalization of distress, where children see their depression as not as bad after experiencing such traumatic experiences. Language barriers, since in the Rohingya language, there's no direct translation of Western mental health terms such as depression and anxiety. Practical issues such as the lack of privacy or limited time during screening. So, the important key takeaway is that first, Rohingya children's mental health is shaped by multiple interacting factors, and we really need a culturally appropriate tool, trained Rohingya workers, and private screening spaces. It is also important to raise awareness of mental health in this Rohingya community by educational programs involving local, community, and religious leaders. And this is an urgent call for action to protect these children's future. Lastly, I want to thank my two incredible mentors, Dr. Ruhul Abid and Dr. Jason Sikwas, for their guidance and constant encouragement, the Haifa family for their dedication towards improving the lives of Rohingya community, the Saxena Center for funding support, to my friends, family, and everyone who are here today. Thank you very much.
Right, next I am so pleased to welcome up Greta List, who's going to give a presentation in the medical student and graduate student category. Thank you.
Hi everyone, my name is Greta List. I'm a second-year Master of Public Health student studying maternal and child health. And today I'll be talking about anemia and associated factors among deceased under 5 children. This data comes from the CHAMPS network, or the Child's Health and Mortality Prevention Surveillance Network, which is in Sierra Leone. So anemia, as many of us probably know, is a condition characterized by low concentration of hemoglobin in the blood. What may be less known is that it's a major contributor to child mortality in low-resource settings, particularly in sub-Saharan Africa. It's often linked to diseases like malaria and HIV, and prior studies have shown high rates of association between malaria and severe anemia at rates around 37%. Additionally, a comprehensive review of 32 sub-Saharan African countries indicated that 76.6% of children aged 6 to 23 months were anemic. However, most of this research focuses on living populations, and we actually know much less about what drives anemia in fatal cases in this population. So in Sierra Leone specifically, and in the CHAMPS network, CHAMPS data shows that a large proportion of under 5 deaths are preventable. This number is 72%, which is huge. Additionally, in the similar period from 2019 to 2024, anemia was the cause of death in a causal chain of 39% of deceased children under 5, which I'll explain what this causal chain means in following slides. But this raised an important question for me. If these deaths are preventable, what factors are we missing and how can we prevent them? So as a little bit of background on the CHAMPS network, the CHAMPS network is a global surveillance system that uses detailed post-mortem data, including minimally invasive tissue sampling, or MITS, to determine causes of death across multiple countries. There are 9 countries that use CHAMPS data across sub-Saharan Africa and South Asia, which I've listed here. What makes CHAMPS unique is that it allows us to go beyond assumptions and identify more precisely what causes death through expert panel review, which is something that's less common in low-resource settings. This was actually the first global surveillance system in Sierra Leone, so it gave us a lot more precise information about what is causing this high mortality rate. This figure shows the CHAMPS process, from community engagement to specimen collection to cause of death determination. Near the top, you'll see the DECODE panel, which is the determination of cause of death panel, which is a panel of local stakeholders, clinicians, epidemiologists, who all come together for each child death and look through clinical abstraction data, MITS data, which is the minimally invasive tissue sampling, verbal autopsy, and social autopsy. And they use all of this data to determine not only a singular cause of death, but the causal chain of death. And when I speak about verbal autopsy, these professionals go with the family's consent and talk to the family about the child's illness to use a standard approach to try to figure out more about what happened leading up to the child's death. So with all this in mind, CHAMPS allows us to determine the true causes of death using post-mortem data. Given this, I wondered what risk factors other than malaria, identified through post-mortem tissue sampling, clinical abstraction, verbal autopsy, and social autopsy, are associated with anemia in the causal chain of mortality among under 5 children in CHAMPS Sierra Leone catchment areas. So to answer this question, we conducted a cross-sectional analysis of 952 child deaths captured through the CHAMPS surveillance network between 2019 and 2025. Our outcome, of course, was whether anemia was present in the causal chain of death, and this was determined by the DECODE expert panel. We also looked at maternal and child exposures. Maternal exposures were age and breastfeeding history, and child exposures included age at death, HIV status, malaria status, and malnutrition status. To analyze the data, we used a hierarchical binary logistic regression, and we nested child characteristics within maternal characteristics. Our main finding was this: the deceased under 5s who were determined to have malnutrition by the DECODE expert panel had over 6-fold increased odds of anemia compared to those that were determined not to have malnutrition. In unadjusted models, maternal characteristics were associated with fatal anemia, and same with child characteristics, but these associations went away when we adjusted for other characteristics. This figure shows the adjusted odds ratios for all the variables that we looked at. And again, what's most important here is that malnutrition is the only statistically significant predictor of fatal anemia in the under 5 population in Sierra Leone. Other factors like HIV and malaria show elevated odds, but of course their confidence intervals cross 1. It's also important to note here the limitations of this study. As you can see, estimates for most covariates were imprecise, with wide confidence intervals crossing unity. This is likely due to imprecise estimates and sparse data. But either way, the one significant predictor remains. This table just shows our full regression results, but again, the key takeaway is consistent with what we just saw. Malaria is the strongest and only significant predictor of under 5 mortality with fatal anemia. So in summary, we found that malnutrition is the dominant risk factor for anemia in children who died, independent of malaria and other clinical characteristics that have previously been associated with severe anemia. This suggests that focusing only on infectious diseases may overlook a critical upstream determinant. Strengthening early nutritional screening, improving access to adequate nutrition, and intervening earlier may be key to preventing anemia-related deaths. Addressing malnutrition could play a central role in reducing preventable child mortality in the under 5 population in Sierra Leone. Thank you.
Okay, and for our third abstract presentation, I'm excited to welcome up Alyssa Vecchio in the postgrad category. Please come up.
Okay. So I am Alyssa. I am a Global Health and Faculty Development Fellow in the Family Medicine Department. I just want to thank you to the Center for the opportunity to share our team's work in describing the impact of point-of-care ultrasound, also known as POCUS, implementation on antenatal care engagement in Western Kenya. You will have the chance to hear from 2 of my colleagues who have led the analysis and a lot of the work in Kenya, but I just want to pause on these other individuals who really make the work possible, but could not be here because they're in Kenya and it's 2 a.m. So, a little bit of a background of Kenya. So our study takes place in this wonderful East African country where the majority of the population live in rural areas, have a median age of about 20, and low doctor-to-patient ratio, all of which is important for this project, focusing on people of reproductive age, trying to access prenatal care in rural areas. So here are just a few photos to get a sense of the conditions in the rural areas of Bungoma County. As you can see, many of the roads are impassable, particularly during the rainy season. The health dispensaries and lower level primary care centers that may be more accessible, like the one you see on the left, often lack diagnostic imaging. So when we focus on prenatal care, we see how these infrastructure barriers contribute to the delayed or low rate of prenatal care in Kenya, which is often far below the WHO recommendations for optimal pregnancy care, which is important, because prenatal care, particularly high quality, consistent, is crucial to decrease preventable maternal and child death. So, which brings us to the question of how do we improve ANC engagement in Western Kenya? And one way is that we can offer more accessible imaging at primary care facilities. So before we dive in a little bit into the project, I just want to bring up that this is part of the bigger project of Empath POCUS Innovation, which is part of a global academic partnership known as Empath, which is a number of US, Canadian, European, and Kenyan academic centers that collaborate to deliver care, training, and research across Western Kenya. And then the actual project, Empath POCUS Innovation, we're focusing on the obstetric portion today, but the actual project is a multi-use POCUS project that integrates POCUS into primary care by combining device deployment and healthcare worker training. And a number of the collaborators are actually here tonight, so we could always answer more questions about the bigger project too during the poster session. And just for what we're talking about tonight, it's the first phase of the project. So the first phase takes place in Bungoma County, and you could see the facilities with the little dots all around the county there. And that was the first phase over a course of a year that we'll be using the data for tonight. And here's a thank you to our funders. And then the next few slides will be two colleagues, again, who have led the analysis and a majority of this project. They will explain the methods as well as the results.
My name is Gertrude Anusu. I'll walk you through how we designed these analyses. We use routinely collected Ministry of Health data from the Kenya Health Information System, known as KHIS. This data is aggregated and reported monthly per facility. We then link this data with program deployment records to determine exactly when each facility began using POCUS. This allowed us to compare outcomes before and after implementation. Importantly, POCUS was not introduced at all facilities at once. It was rolled out in a staggered manner over time. To evaluate the impact of POCUS, we used a difference in differences approach following Callaway and Santa Ana method, which is well suited for staggered settings. We compared changes in outcomes over time in facilities that received POCUS relative to changes in facilities that never received POCUS. We focused on antenatal care utilization outcomes, which had reliable KHIS data and sufficient sample size to support a rigorous analysis. Our main estimate was the average treatment effect on the treated, which captured the impact of POCUS deployment. Facilities that never adopted POCUS served as our primary comparison group. Finally, we conducted a sensitivity analysis to assess the impact of missing data on our findings.
And just our next speaker is actually a PhD candidate at Brown. He's currently in Kenya and again shared the recording here.
My name is Richard Mugo. I provide biostatistical support to Empath research programs. I'll now take you through the result. POCUS program began giving health facility devices after training healthcare workers earliest in February 2025. By October 2025, the program had equipped 118 health facilities and trained 507 healthcare workers in obstetric POCUS. The program was implemented in both lower level facilities, that is level 2 and 3, and higher level facilities, level 4 and 5 in Bungoma County. Notably, all of these facilities received devices at different times after the healthcare workers received required training. Here, we are looking at antenatal care revisits, which capture how often pregnant mothers return for care. The dashed black line marks no difference between POCUS and non-POCUS facilities. On the left, in the pre-implementation period, the estimates in red move around that line, and their confidence interval cross it throughout. So at baseline, on the same note, When we looked at antenatal care new visit, we capture number of new pregnant mothers that seek care in these facilities. We see that in the pre-implementation period, the estimates and confidence interval in red moved around the null line, implying no clear difference in new visit patterns between POCUS and non-POCUS facilities. The pattern, however, changes during the after implementation. The estimates and confidence interval in blue move upward and increasingly stay above the null line, indicating that new visits in POCUS facilities are higher compared to non-POCUS facilities over time. When we summarize this using the difference in difference approach, we find that POCUS implementation is associated with a 38% increase in antenatal new visit. This is a notable statistically significant increase in new antenatal care utilization following POCUS deployment. I will now walk us through the missing data sensitivity analysis. Some monthly data from POCUS sites were missing in the KHIS system. We assume that the missing numbers were lower than the one we observed. This means the real effect might be smaller or absent. So we reduce the mean of the observed value and use this smaller number to fill in the missing data, using what we call delta downward shift. For example, a delta of 1 means the value is reduced by about 63%, which is a big drop. Even after this big reduction, the POCUS effect remained and was still statistically significant. This shows our results are strong, even when we make tough assumptions about missing data.
So, in conclusion, early findings during the pilot phase of the study suggest that implementation of POCUS at primary healthcare facilities in Bogoma County is associated with a statistically significant increase in both the initiation and the continuation of prenatal care. Further research is needed to see if the intervention is sustainable and scalable across the region, particularly linking to maternal health outcomes. And again, here's just a thank you to our fantastic team members. You might notice them in the crowd today. And I am happy to answer more questions during the poster session.
I will also note that there is a cash prize associated with the best abstract, and so all three of them will be receiving it soon. All right, for the very final portion of our Global Health and Equity Symposium, I am delighted to present the Susan Kouvin Global Health Leadership Award. This award is the highest honor that our Center for Global Health Equity can bestow on an individual, and it is named after our former longtime director of the Global Health Initiative, Susan Kouvin, who led global health here at Brown for 15 years between 2009 and 2024. And this year, I am absolutely delighted to present the Susan Kouvin Global Health Leadership Award to Professor Timothy Flanagan, my mentor, my colleague, and for a few hours once in Liberia, my student. Tim has been a clinician, researcher, educator, mentor, and leader in global health and health equity at Brown University for nearly 4 decades. He served as the primary investigator on several NIH-funded training grants, which aim to prepare students, fellows, and junior faculty for careers focused on HIV, emerging epidemics, and health disparities. From 1993 to 2017, he served as a mentor on an AIDS International Training and Research Program grant, and as the primary investigator on a higher education for development grant to build HIV/AIDS education programs in Ghana. He spearheaded the Brown-Ukraine collaboration more than a decade ago and is now the co-PI, along with me, on an NIH Fogarty-funded program building capacity in HIV, TB, and mental health in Ukraine's humanitarian crisis. Tim has also collaborated on HIV/AIDS clinical research projects in Ukraine among substance users and was a consultant on the CDC-funded Modified Antiretroviral Treatment Access Study with the Ukrainian Institute of Public Health Policy. Closer to home, here in Rhode Island, he has over 20 years of experience spearheading NIH, CDC, and HRSA-funded research grants related to HIV, infectious diseases, substance use, and other comorbid conditions. These projects have included an evaluation of HIV, sexually transmitted infection, and hepatitis prevention interventions among young men being released from prison, a randomized controlled trial which demonstrated a significant short-term impact of modified directly observed antiretroviral therapy among active substance users, and 2 previous Ryan White HIV/AIDS program special projects of national significance. More recently, he has led the NIH-funded training awards on HIV and other infectious consequences of substance abuse, as well as the Emerging Infectious Disease Scholars Program here at Brown University, of which we have many trainees who have been funded over the years. He has published nearly 500 scientific manuscripts, book chapters, and other scholarly work over the course of his career, and given hundreds of invited presentations at local, national, and international events. Perhaps most importantly, he has left behind a legacy of dozens of trainees at Brown University and around the world who have gone on to have successful careers in global health and health equity in their own right. Please join me in congratulating Tim as he accepts his well-deserved award.
From Professor Levine. So of all those symposiums I've been to, this is about as good as it gets. The most rewarding work I've done has been in my collaborations overseas, and I encourage you all to jump in. It's just been a wonderful adventure, and it's been a gift to me. I've been very blessed by my friends, colleagues, both here but especially abroad, that have worked together with us. So thanks everybody for being here, and keep up the great work.
Okay, so as we conclude our event, I just have a few points I wanted to make. Firstly, I want to give some important thank yous. I want to thank our entire Center for Global Health Equity staff and student assistants, and that includes Eileen Wright, our program manager, Megan Faragne, who is our program coordinator that helped support and organize this event, as well as David, who is our International Medical Exchange Program Coordinator, Laura, who is our program specialist that runs our HEADS program, and Joanne, who is our program coordinator that supervises many of our research studies. And then, of course, Leslie and Naomi, our fantastic student assistants. Without all of their help, none of this could have happened. I also want to thank our Global Health Advisory Committee. It's composed of about a dozen faculty, students, residents, and fellows here at Brown who help organize and lead all of our global health activities through the Center for Global Health Equity. I can't name all of you right now, but thank you. For those of you who are here, please stand up and be recognized along with our staff. So in a moment, I'm going to dismiss everyone to join our poster presentation. I'm going to first ask that we allow our poster presenters to go out and get some food first. So let them get food first from the line so that they can then go and present at their posters, and then everyone else will be able to get food after them. So all of our poster presenters are dismissed right now to go get some food and get ready to man their poster. I also want to encourage everyone else, after you've had a chance to get your food, to please visit all of these amazing posters. We have 60 posters here tonight, which is the most we've ever had at one of these symposia, and all of them represent the hard work of students, residents, fellows, postdocs, who have been working on research and education projects all over the world, including here in Rhode Island. And for going to these posters, you get a special prize. So on the back of your agendas, you can see a bingo card. Each bingo the card has a number of different categories. If you go to a poster, you get the poster presenter to sign their name on that category. And if you fill up this card and give it back to us, we will enter you into a drawing for a fantastic Brown University hat. We have a number of them. There is a high likelihood of you winning this hat if you fill out the card. So please, that is an incentive to visit all of the posters, or at least, 15 of them, so that you can fill out this card. And that free space, you can choose any poster of your choosing to fill in the free space. So with that, I also want to let you know that we have here free Plumpy Nut for those of you who are inspired by Naven but really curious what it actually tastes like. You can grab your own Plumpy Nut and take it home with you. We ask that you only take one. And please enjoy our poster presentation and enjoy the dinner that we have here today for you. Thank you.